Thank you, madam. You can start.
Yes, Pooja, I think maybe not call it a MCQ test. It's not a test. It's just the nice words that Dr. Bhomik used. What was it Dr.
Review.
Meenal used? Review questions. All right, it's review questions. It's not a test or anything. And so don't worry about it. Don't fret about it. I'll see if I can um I don't know. I have not given all the slides, but if the slides are, are needed, but it's not needed. Just have fun and then later on look at the answers. All we want is you to have learned something new. So let me go and um, start today's talk. What time is it? Okay, so today we are talking about challenges and opportunities. It's like a whole, it's a whole, the complete, it's more like a complete picture if you look at it and based on kind of whatever we've done so
Recording
far.
in progress.
So you and I also to give you a total picture of the cancer scenario, and not just molecular, not just imaging, but everything kind of like together. And so what I kind of did was that I kind of like focused this on um, the subtopics here are cancer cell heterogeneity, which we will look at, and then resistance to therapy. And so that is, and then so what are the opportunities that we have from there? But with you cannot just keep going on these topics unless I now give you a full picture. So I just want to talk about colorectal cancer as such. Actually, yesterday I was saying that I would show you my own experiments and images and animal models, but I just realized it just doesn't fit here. So I took it out and can share another time. So colorectal cancer is what I'm trying to just first of all I'll go through clinical aspects, so that you have an idea of how the whole process goes through, or how what the clinical aspects are, and then we will start with the challenges. So a clinical look at a cancer, and then we have chosen here colorectal cancer. So, so this is a graphic. These are called as infographics, as you know, and they give you all the information of how many people are getting it today. And so, since I have data from either a company, this is from Genentech, or from the American Cancer Society, ACS, we pretty much take from there. And this is Genentech's. It's an infographic of warning signs. It's a very nice way to present these days. In India, I also saw some flyers like this. So it's all in one. How many people will get it. So catching CRC is early and important. If you get it, too late, survival is kind of like poor. Will get poor. And so a lot of the people who get CRC, they're typically 50 and older. So the older you get, you can get colorectal cancer, right? So just a couple of things that are in here. How many people get it, just to show you that there's such a thing as an infographic. And the fact is also that there are certain risk factors to colorectal cancer, and it is really based on family history. A lot of the people who get it is based on family history. That's about 20%. It's called familial colorectal cancer, and some of it is dietary factors, uh, and that is about 30%, a little bit higher. Western diet very uh, promotes colorectal cancer. Animal fat promotes colorectal cancer. And of course, there's the age. So, depending on diet, colorectal cancer can spontaneously develop. But if there's a mutation in the family, then they will develop after the age 50. So, oops. So, some some pathobiology or pathophysiology of CRC, and now I like to include them because it seems that you we have talked about these words. We have used all this verbiage already. So, what are the kind of factors? And some of these are kind of like in your questions also today. Not just from here, but because we covered already. The special genetic mutations, and I might have just told you one time that there is the APC mutation, that there is an APC mutation, and so if that mutation will drive it, and there's a couple of more mutations. The tumor microenvironment plays a role once the tumor is established. In the beginning, a tumor kind of faces difficulty to establish, but then later on, it gets the help of the whole tumor microenvironment, and it tricks the microenvironment into helping. And then there's an inflammation role. If there's chronic inflammation, that always leads to a cancer risk. And so this is like one of the initiation parts. It'll happen in the beginning. Then metastasis. Metastasis is happens afterwards when it has been broken away from the basement membrane. It's bigger than a polyps, and that's how metastasis. We have studied that already, and all the genes, etc., that were important. Immune invasion. By this time, the tumor, when it's bigger, it is able to completely evade the immune system. The immune system cannot even recognize it. And so we saw some immunotherapy yesterday, remember? CD19, where we are now using that's immunotherapy, where we're using something, a marker like that, and with antibodies that can either activate or neutralize. So essentially, a new immune system is smartly evaded by the cancer cells. And then at the clinic level, there are clinical biomarkers for diagnosis. How does one diagnose these? So every cell surface has certain biomarkers. There are certain proteins that individual cells have that others don't have. So those are used as biomarkers. And finally, screenings are extremely important. And colonoscopy is done at the age of 50 onwards in Western countries to look for the polyps. Remember, the polyps are the precancerous mushroom-like structures. And so this is for colorectal cancer. If you look at now, you remember the staging. We had talked about some kind of like summarizing things we did so far. So in terms of staging, the stage that is still intact and held together at the membrane, that is still at the stage of 0. All right, mostly stage of 0 if it is not escaped, but if it has escaped a little bit, if it has escaped some more, all right, so then it picks up a stage number. So the first one is called as a polyps. Okay, it's still at a point where it can be salvaged. Then there is dysplasia, and then leads to adenocarcinoma. Adeno means that it is glandular, it has glands, and it is also secreting things. And then finally, it becomes malignant. And so when remember also, we talked about lymph nodes. I can't remember when, yesterday. That is goes equivalent to stage 3. And once it has separated out and gone to other locations, it's stage 4. So lymph nodes could be, early lymph nodes are either it's there or it's not. Genetic mutations in colorectal cancer, these are what people look for. And so you don't need to memorize any of these. I'm not asking you anything from here. But just that so that when you leave this workshop, you have heard of these mutations. A KRAS mutation, RAS is an important oncogene, and it's one couple of mutations will really lead to this uncontrolled cell proliferation. And similarly, so RAS mutations, that's all you need to know. And you did learn P53, doesn't matter, you can just call it TP53 or P53. And that was a tumor suppressor. So remember, I'm revising today also. So that was a tumor suppressor that if there is a mutation in the tumor suppressor, then there is genomic instability takes place and malignancy, cancer occurs. And so please do remember that I forgot what I wanted to say. P53 is a tumor suppressor, so is RB. Oh yes, just a reminder that 50% of all cancers, okay, typically 50%, 40, 40 to 50% of all cancers have a mutation in P53. So remember, mutations accumulate, and that's why cancer takes place. All right, and then so the other ones is RAF or BRAF, and then it's fine that you the again its mutation um, initiates and promotes. And then mismatch. We never really talked about mismatch, but this leads to mismatch repair. The DNA is always making mistakes, and we're always fixing them. So if there is not enough repair, then that leads to, the word would be that it leads to genome instability. Okay, that's genome instability. And it leads to microsatellite formation. So microsatellite, I'm sorry, the microsatellite instability. And so mismatch repair genes. And so all of these, they start to progress, one mutation after the other. You learned that they keep on, one mutation accumulates and others accumulate. So I'm saying that because these will all lead to what we're going to talk about. One mutation leads to another, okay? And they're not in sequence. Nothing happens in sequence. They can just happen. The more mutations there are, the worse things get. So those are in a testing in a clinical environment. Those will be examined, and so the tumor microenvironment, you also learned, plays a very important role. So vascularization takes place. Blood vessels will be made, and you saw how there are two ways to make blood vessels or to go towards blood vessels. And then the immune cell interactions, either they ignore or they just are useless. And then there are signaling molecules that start to, because they're mutated, they produce more signaling molecules. Metabolic, what did we say about metabolic? We said that for metabolic processes, that these cells, cancer cells, will use more glucose. They don't care much about for oxygen, and so they're kind of distinct. So they're using glucose, but they're going to remain kind of distinct because they are metabolically very active. So they process that glycolysis process fuels the tumor development, the tumor grows. And then there's a whole ecosystem. It's like a fish tank. There's fish in it, there's bacteria, there's plants, there's a little bit of fungi. It's a whole ecosystem that the tumor may or may have to overcome and utilize. And of course, the cells in the tumor are there itself. So we had used the word stroma, if you remember. So now some pathological classifications of colorectal cancer types. So there are three major types, and the most common type is the adenocarcinoma, and it's called as yeah, it is a adenocarcinoma. Thus, the other two are carcinoid, or they are lymphoma. So it originated at the well, at the lymphatic system. It originated in the lymphatic system and very quickly spread to and caused colorectal cancer. So three types. And so clinically, what is one supposed to, look for? What are the clinical manifestations? So for this one, there can be, it's just a matter of time, but there will be, let's say, rectal bleeding. So there's rectal bleeding, and this rectal bleeding will not be occult blood, it will be fresh. Um, well, no, sorry, you're making a mistake here. It may or may not be dark colored blood. It may not necessarily be fresh blood. And so rectal bleeding, if it comes out in the stool, it'll look like coffee, ground coffee, and that it means it's rectal bleeding. So there will be of intermittent pain, but a major thing about colorectal cancer is intense pain, and people who suffer from it have terrible pain. Change in the bowel type or consistency, big weight loss. You're not trying to lose weight, but you're losing weight. That's a matter of concern for the patient. Uh, a lot of fatigue, nausea, loss of appetite, and typically for CRC, people experience a bloating, feeling of fullness. So those are some symptoms. So how are they diagnosed? Okay, so I thought that we can compile everything that we've done so far, kind of like put it in together and just review that how they techniques, how they diagnose. So typically you can use, we have to diagnose it in order to take a image it, sorry, we have to do a diagnostic imaging in order to look at how far it has spread and to give it a stage. So it is a CT scan is required for staging. And depending on, some of them have radiation, some of them don't. MRIs doesn't have any radiation. So it depends on the convenience also. But anyway, these are very, very common. And so the CT scan would be used for identifying staging and looking for metastasis. MRI that we examined in a video, it is useful the in evaluating tumor invasion. Did it go to any other organs? Did it go to the pelvic organs? And I told you these cancers, they go to, specific locations. If it's there in the colon, it'll probably go to the liver, and it'll probably go to the bladder. So so MRI for that. Ultrasound can be used for local for looking at lesions, etc. um, and for biopsies. And PET scan, we saw yesterday that the PET scan is used to look at for the metabolic activity, the hyperactivity of the tumor because of its glucose utilization. So those are all the major imaging techniques for the full body, uh, over the for the body of the patient. And some biomarkers for you to understand. Frequently, these biomarkers are going to be examined for their presence, for how much they might be, for what is it. So some of them, so there are some tumor markers called as CEA. Okay, no need to memorize them, just giving you an idea. No need to memorize this for any quiz or anything at all. And so there are those markers that you just have to keep on testing in the blood, and so that's used for monitoring. And so these are used for monitoring. Let's say if there was a recurrence, if the cancer is coming back again. So these are used for monitoring in the blood. So these are fairly easy to do, but one need to probably look at the to really look for what the mutation was in that cancer. Where did the cancer start from? It might have more mutations, but at least a couple of the major mutations are RAS. Okay, you can just call it's called as RAS, uh, various types of RAS. So KRAS in this case. And so where would you look for it? You would look for it in the tumor. So you can ignore these numbers. And so why are we looking at? Because if there is KRAS activation, then we can go for targeted therapy. We can, we can look for what, uh, how to target rather than, along with chemotherapy first time, or to be able to target it much better without doing too much harm. So this will predict some kind of response. So whenever there is a cancer, to predict the response, to predict the treatment also, and to predict the response, a genetic mutation is always examined. So the genetic mutation will be examined so that one will know what to do, okay, what to attack or what to fix, not fix, what to treat. And so other molecular signatures are one is this is you will look at this in the tissue, and this is a prognostic tool. What does a prognostic tool mean? That means predicting how the therapy will how the therapy is working. So or how the therapy will work. So it's more like a insight is to, to predict if there is too much or too less of this new particular marker, then maybe that they will, it gives insight into how effective the treatment is going. And so there's all guidelines and criteria. So essentially, for a summary, just to say that there are CEA levels that you look for. Is the disease advancing? Is it progressing into metastasis? Then you look for KRAS mutation, so it will tell you that that certain therapies just won't work. Okay, and so it's best to go for a targeted therapy because this is a really aggressive kind of a mutation. And then MSI will tell us, that um, is the therapies working, because then this is a status to tell you, oh, things are kind of like working at the back door. So it's kind of a prediction for future. So again, it's just for your learning. There's nothing from here to be taking for the exam, but I hope you found it interesting. So biomarker, these are biomarkers, or maybe that they have a role in causing the disease, or maybe they are just indicators of the disease progression. Is that okay? So they may not be the causative agent. In this case, it is, but they may just be indicators of something. Okay, just um, they may be secondary issues that just came up and they indicate something. So that's so treatment options by stage. At stage 0, if there's a polyp, fine, we'll just take it off by a colonoscopy, put in a camera in, and just something like a scalpel. I don't know the word, and they can just be removed. And so every 5 years by colonoscopy, a person aged 50 and above would just go and remove the polyps. And sometimes when people don't, the polyps gets much bigger. And it's not like, every person age 50 is getting it, but some people have a tendency to, and your diet also. So stage 1 and 2. So the first thing first is when one finds out that he or she has stage one, stage one, that it's passed through the membranes, then there has to be some kind of surgery, and the surgery has to be decided how much of the colon are they going to um, resect out, how much of the colon are they going to take out. And so this will happen if it's too big, then first it has to be done with chemotherapy. If it's not too big, then maybe it's not with chemotherapy. And if there's a stage 3, then first there has to be surgery, chemotherapy, and if possible, because it might have spread, if possible to, it give it more, immunotherapy. And we looked at some immunotherapy yesterday. Stage 4 is really the bad scenario where it has really gone out and spread somewhere else. And so you can try whichever works, whatever works. So secondary cancer is the cancer that happens when it has gone to another location. And it's kind of like strange from the secondary cancer. There's no such thing as that the secondary cancer then progresses to a tertiary cancer. There's just it's not like that. Um, so treatment modalities, surgery, first of all, has to be kind of like uh, how much of a surgery can is required. Should it be minimal? So can it be laparoscopy? I hope you know what is laparoscopy. There's just a little they don't cut open the whole abdomen. They cut open a very small cut, and they put in a camera through, and from the camera, or from that little space, they can just do whatever needs to be done. And this, it's just like a little stitch. You come out, and next day you can go to work. So it's minimally invasive. And um, so that is only if, on a very, very early location or some kind of, this is a very special technique. And it might be one of the techniques that is easy to do. So not all of them would be laparoscopic. And of course, there's post-operative care if there's a bigger kind of a surgery. And this is just an idea to give you what chemotherapies are like. And so I don't need you to look at everything, but I do want you to look at the bottom here and just to say that these are different names of chemotherapy regimens. They're like combinations. That's why they sound so weird. They have these weird names because they're a combination of this and that, 5-fluorouracil, oxyplatin. So that's why they have that name. And so are they efficacious? What does efficacy mean? Efficacy means that the tumor has gone smaller. And um, so if the tumor gets smaller, then that's a good sign. And if it is possible to administer it orally, that's good. But typically there's these are given IV. All right, and some things are given. Most of them will be given IV first, and then some of them will be follow up as oral. And so you look for good response rate for these are different drugs. There are like 4 different combinations here. Okay. 4 different combinations. Oh, the 4 are here also. So these are the 4. And I just wanted to say that there are a lot of side effects, of course. Lots of side effects, diarrhea, etc. Neutropenia, because you're giving it through the blood, so white blood cells will kind of like really become less. All right, so white blood cells, so your immunity will be really less because of chemotherapy. And so a person coming out of chemotherapy is very, very sensitive and needs to be given a injection of white blood cells in order not to get an infection. Um, so that's pretty much it. Side effects are really anything to do with killing all the cells. So chemotherapy is killing more, normal cells as well. And so the rest is kind of like easy, and I can just run through them very quickly. Oops, sorry. So radiation. So radiation therapy um, can be required for um, for locally advanced colorectal tumors for locally for locally advanced colorectal tumors. So if there is a bigger tumor and by surgery it's going to damage a lot of blood vessels, and by surgery might be risky because then you might have to take a bigger part of the GI tract out, and the person's intestine becomes smaller. So for before you do surgery, you can start out with radiation, and radiation will kill a lot of the tumor cells, and they will become a smaller tumor, and then surgery is done. So radiation can be done with chemotherapy to make it more effective. And radiation is these days it's so precise, it's so nicely precise that radiation can target just the tumor and not the surrounding issues. So there's minimal damage. So radiation technology has really improved over the years, and the remaining tissues are not hurt so much. And it's good that you can shrink the tumor. It'll take some days, and then you can do the surgery. Right. So there are some. So what are targeted therapies? Targeted therapies are always kind of preferred. So we just did targeted therapies yesterday. So one of your good ones is monoclonal antibodies. There's a bunch of monoclonal antibodies. If one doesn't work, if you know mutation is, or which is the hyperactive protein, then you just target that with that monoclonal antibody. And so it is very, very targeted. And so what it will do is that it will either inhibit the receptor, it will inhibit something or the other, or such that there is no signals that can lead to the cells to multiply. So inhibitors, anything I told you that ends with the NIEB is an inhibitor, and so you don't need to know the details of tyrosine kinase. That's fine. Just know that there were some inhibitors that we had discussed, and that's when, because you know which is the molecule that is activated, so you just go and inhibit that directly. And so this is also extremely efficient. So that means when you are screening for the cancer, and initially you're looking for all of these markers, because then that will decide what the therapy will be like. And immune therapy is not like mono anticlonal bodies, but immune therapy means we're just saying that the T cells get nicely activated to be able to see the cancer cells and therefore destroy the cancer cells. Remember that the cancer cells tell the T cells not to look at them. They can hide very easily, but now the T cells are able to find and see these cancer cells. So that's your immunotherapy. And combination therapy is for, a bunch of things together. And there's always clinical trials that are going on. Some people, they are very, very, they would like to enroll in a clinical trial because of a new agent. For example, there are several cancers that when you have somebody who's in their stage 3, stage 4, and would really like to, give it a try. What's the harm? It's not going well. They also like to go into these clinical trials. But unfortunately, not unfortunately, in clinical trials, that person doesn't know if they are getting the placebo or if they're getting the real drug. And even the doctor doesn't know. Nobody knows. Those are all just given in a computerized random way, such that much later on, they will find out if they were given the placebo or they were given the drug. So, immunotherapy a little bit more. We talked about CAR T cell therapy yesterday, and I'm thinking that you really liked it. These are customized. These are your special antigen recognizing T cells that will go and find. They will kind of like go and find the cancer cells, and then they will be able to um, destroy them. They It's a tag mechanism, and they'll just tell them to die. So that's one. And microsatellite instability, we didn't talk about this, but I hope you can just remember this word. Microsatellite instability simply has to do with the some kind of chromosomal with a chromosomal defect, and so these are all a result of DNA repair enzymes that don't work, and the DNA doesn't repair properly, and so that leads to microsatellite instability. So it's a uh, genomic way to treat the cells. It's because of the genomic problem, because we've identified that. So checkpoint inhibitors. Remember, I said that they were the cell the cell cycle has certain checkpoints, and those there can be drugs that can these cancer cells, they evade those checkpoints, and so we can give drugs that work at those checkpoints. Alrighty. The rest is all, what do you need in the US? How do you support this patient? What is the palliative care? What is the patient support? Just wanted to show you that pain management is a big thing in the US. Pain management, they take it very seriously. If you want management, you can get very strong drugs to do that, so they take their pain management very seriously. Their point is that there's no need for you to suffer. So pain treatment is very, very They believe in brain treatment. And so there has to be special nutrition, psychosocial, there are social workers, etc., that provide emotional support. There are focus groups, etc. You have to go to a psychologist also to make sure that the person who's going treatment for colorectal cancer is not suffering through too much of anxiety and depression. So there is a psychologist also on board in the team. And then the team makes sure that you have enough physical activity. And if there is a end of life planning, then they will also provide you so the medical system here will provide you a social worker to talk about that. These are not easy things to do, and most people, it's not like everything is set in stone. But the point is that I'm just trying to say that there's a um, lot of surrounding treatment, surrounding care that goes around this. And so it's called as together, everything is about the quality of life. So in a quality of life issue, all of these have to be discussed. And if you really, wanted this specific food that you're craving for, nobody's going to say no. You'll still they'll still try to get it to you. So it's all the same previous things before, but they are managed for a good quality of life. So your QL has to be also met. No one should say that because you have this cancer you cannot go out and do this and this. You want to go out, we'll help you do that. That's the way kind of it is. So so future directions for this is that there needs to be, if you can identify unique genetic markers, then that's always good. That then you can treat accordingly. Very, very, um, a very direct and very precise way of treatment. So one would look for more biomarkers if there are any. Innovative therapies, that means you combine, immunotherapy um, uh, if the conditions are right. So, it all depends on what the tumor is like. And so, are you a candidate for immunotherapy? Is the patient a candidate? And finally, there has to be treatment preventive strategies. And what that means is once the surgery is done, once the surgery has been completed, and the person has gone through chemotherapy, etc., and is in remission. Remission means that the cancer is gone, the tumor is gone, let's say after 6 months to a year. Then, for the next couple of years, there has to be a prevention plan. So there has to be something that has to be given or taken by the patient so that it doesn't come again. So that would be like, let's say, taking a small dose of some food items that are cancer preventive. And prevention strategy also means for those people who never have it to identify the risk factors and to work. So if you know you're in a family where there is dietary based colorectal cancer, then you would like to start changing your diet early on. So there is no initiation. There's it. Okay, so I can think these are all the same things. It's just a conclusion to say that everything is combined together in order to make sure that there is a total treatment plan. And with this being the end of this colorectal cancer, I hope I was able to give you a total understanding of how at least colorectal cancer, if there is a patient, how their treatment modalities go and what happens. So all of this can take several months. Um, so let's go and look at what we wanted to talk about today. And I kept it rather simple so that I would be able to, so, the language is also a little bit simple. So we're talking about cancer cell heterogeneity, and we're talking about resistance to therapy. They're not two separate things. They're just one leads to another, that kind of thing. So cancer cell heterogeneity, let me just see. I need to put on the video so I can see some more folks. Ah, nice to see so many faces. I had to just look at the slides for a bit. See, in my classroom, I cannot, if I do a Zoom, I have to have video on. It's a mandatory requirement. So, how can we talk just to a blank screen, right? So it's good to see you. Thank you. Um, let's admit this person. So now let's talk about cancer cell heterogeneity. So which was this? It's really about challenges and opportunities. That's what it's really for. So, so if we just stay fixated to colorectal cancer, then I can just tie it all in. So, so colorectal cancer does exhibit cancer cell heterogeneity, and so what does that even mean? Uh, so, and colorectal cancer does show resistance to therapy. I mean, a lot of the cancers do. And so, what is this heterogeneity? Intratumoral heterogeneity, okay, or heterogeneity, whichever way you want to pronounce it. Intratumoral heterogeneity arises. So intra means inside the tumor. So it is it's not inside the tumor. It's the wrong way. It's within the tumor. That's all we just want to say. It's within the tumor. And so we're not talking about the stroma. We're not talking about the about the blood vessels right away. So we're talking about just the tumor cells itself. So that is one thing for right now. And so, it arises. How does this heterogeneity? As I have a diagram, just give me a second. It arises from these genetic and epigenetic differences. Genetic differences is mutations took place. So if you have a we just said the cells are multiplying. If they're multiplying, then they should all be the same type, right? So, but if they multiply and during that multiplication, some of them accumulates a second mutation, that's a lot of that's a lot of cell division, right? If cells continuously divide and they're not really doing work for you, then it's possible that they can get some more mutations. And so that's genetic mutation. So it comes from number one is that one leads to another, one leads to a genetic mutation. And then there's these epigenetic differences. Epigenetic means it is not a mutation. It is not a mutation, but it is changes to the DNA. And it is changes to the DNA, like the DNA takes on a methyl group, or a DNA the DNA has certain small changes that are inheritable, and the next cell inherits it. So it's almost like a mutation, but it's not a mutation. Nothing changed, the basis did not change, but the DNA just modified itself a little bit. All it did is, like giving you example, a genetic mutation is like I replaced my forefinger and I replaced it with the wrong finger, I did a surgery on my thumb and I replaced it with the wrong finger. Go figure. Can you do work? No. So that's like the weirdest example, but an epigenetic means I'd have my five fingers, but on one finger I decided to wear a ring. On the second finger I decided to wear a different ring. And the rings are just so big that I'm not able to pick up my utensils, or I'm not able to do what I'm supposed to do efficiently. And then sometimes if I'm wearing a ring that's so large, then I can't even, bend my finger properly. And that is epigenetic. So it's like a little extra thing that it's not a change in the DNA. It is on top of that. So it's an epigenetic difference. And the problem is that now that I'm wearing on my finger, I'm wearing a ring. Then I don't know how to say this, but the next cell that divides will also have that ring. Okay, all right. So none of the DNA is mutated, but it'll just have the extra ring. So now you have an extra problem where because this is being given to other cells. So genetic and epigenetic differences. And so it gives rise to all these different subpopulations. And so so one type is what we're going to talk about is these cancer stem-like cells. Okay, we're calling this stem-like cells because for colorectal cancer, they are stem-like kind of cells. That's why. But I will really in future be calling them cancer stem cells. All right, so cancer stem cells, and we will talk about what is a cancer stem cell and what does it do to contribute to heterogeneity. So cancer stem cells are now present in the tumor and they are diverse and they differ in proliferation. Some of them are slow, some of them are a little bit faster. They have different properties. They invade differently. Some of them will invade, some of them will not invade, and some of them are sensitive to drug and some of them are not. So let's look at so heterogeneity by these cancer stem-like cells. So what is a stem cell? A stem cell, let's go back for a bit. Forget the cancer and let's just talk about a stem cell. What's a stem cell? A stem cell is like, let me give you an example. You know, I told you that in your GI tract, every 3 to 5 days, you have new cells. Did I tell you that? So in your GI tract, because of all that enzymes and acidity, etc., every 3 to 5 days, the cells die and new cells are made. And I showed you a video also about the crypts and the villi in the GI tract. So at the bottom of that, at the bottom of that, in your GI tract, in the inner layer, there are these small stem cells that will then give rise to normal working cells of the colon or and the GI tract. So stem cells are like you but stuck in time. Stem cells are like me. So my stem cell would be like me when I was back in 20 years old. All right. And so if I wanted that 20-year-old me will make another 20-year-old and we'll start all over again. So it's like going back in time and starting a fresh one. So a stem cell has all the original features. And a stem cell as it grows, so a unique thing about stem cell, okay, we sorry I had to track this, but I without that I can't move. A stem cell can become whatever it wants to. A stem cell can become a skin cell, a stem cell can become a cardiac cell, stem cell can become, hopefully one day, a neuron. And so a stem cell has potency to become a different, to specialize and to differentiate into something good. So you can understand that a stem cell has all of these magical characteristics, just, as a simile, I'm saying that. And so this stem cell has metabolic variability. Some of them can grow fast, some of them grow slow. They have a lot of variability. And so if those tumor cells, one of them is like a stem cell, a cancer stem cell, so then they will start to make different kinds of cells. So they are these hence these stem cells are subpopulation with a slightly different metabolism, and they will keep on making different kinds of tumor cells of different clonal types, and some of them will survive therapy, some of them will just not listen to the drug, etc. So some of them will keep on coming back. And this is found in colorectal cancer, in brain cancer, and in pancreatic cancers. All right? At least they're important in them. So let's look at this now with a diagram. So when I gave you that example, there we go. So tumors of these colorectal cancer, they have this heterogeneous population. And so take a look at this. I want you to look at, you can look at both. Can look at both. So there, so how did we get this heterogeneous population? Because of stem cells. So there are two ways that you can get heterogeneous cells. So a stem cell So look at the stem cell here first. Look at on the right hand side. A stem cell, a stem cell will is your original cell. So here's your stem cell. And a stem cell has this really weird characteristics, really unique characteristic that it can make when it divides into two cells. So here's, A divides into B and C, right? B and B. And what it does is a stem cell will make itself. It will make a complete like itself, a clone of itself, and it has a lot of good properties. It can be whatever it wants. What is a stem cell? It can become whatever it wants to. And it will make the other one that it made is slightly differentiated. It has slightly different properties. It is deciding that it will have a different property. It'll be a tumor, but it will secrete this. It will secrete something, or it will, behave a little bit differently. So it is not a stem cell anymore. So this one is not a stem cell. All right, so this is not a stem cell. So a stem cell was this one, and this one is a stem cell. And then again, this one divides. Look at here. This one divides and this one divides. And what is it producing? Another stem cell, but then this one is not a stem cell. It's a slightly different cell. It's a slightly different cell, but similar to the first one. Now let's go back to the first one. This one divides, and when it divides, it produces a two cells that have slightly different properties than the parent cell. So they're both yellow in color. So it will have slightly different metabolic properties. I can't tell you which one it is. Maybe it'll have slightly grow faster, grow slower. Maybe it'll take more glucose, less glucose. It will have slightly different properties. And so now what do we end up in? We have now in this tumor, in this one tumor, we have the original one, the red one. Then we have some of the pink type. So the original one is the stem cell. That's the cancer stem cell. Then we have a pink type, and then we have a uh, yellow type. They are not stem cells anymore. Okay? A stem cell is the mother of all, that original cell that can become whatever it wants to. And it'll stay there, and it's it's waiting to do this job. And so what happens now? You have a tumor that has not exactly the same property. Okay? So that is the cancer stem cell model. And the other model by which cells can, by which cells can become, the tumor can become heterogeneous, is simply the clonal evolution model. What's the clonal evolution model? So this is number 2. And clonal evolution model. And I'm saying these because there are ways for people to do machine learning work on these also. Have AI driven understanding and recognizing these. So that's why it's good that you understand this. So in the clonal evolution model, in the clonal evolution model, there is this original cell, okay, and so maybe it's a stem cell. Let it be red. That's fine. And then you see this lightning. So that's like some kind of UV irradiation or something like that. And it's got some irradiation. Picked up some gamma radiation or UV radiation or some kind of radiation or some carcinogen, and it led to a mutation. And so it led to it produced it during division. One was normal and the second one was slightly different. So this was mutated. Now at some point of time, it divides, the pink one divides, but at some point of time, it also divided one day and it produced one of its normal ones, but another mutation occurred. And so you end up with these different kinds of cells and they're all in one tumor together. Okay. They're all in one tumor together. This yellow one has different properties. The yellow one has the yellow one has slightly different properties. Maybe it has an extra mutation. Who knows? Really bad. That's bad. It has an extra mutation, and this one doesn't have an extra mutation. That one has the original mutation, and this one has a different mutation. And so now they're all going to be in the tumor, and that's going to make it that's going to make so this one a completely heterogeneous tumor. So this one might be able to make blood vessels. Okay, maybe it's good at making blood vessels. Remember we said that yesterday. How did that happen? And so this is the model, so it makes blood vessels. This one will go and tell the T cells to shut down, don't recognize them. So T cells, it will go. So not everybody's doing the same thing. So it's like a neighborhood of people. Has different. Everybody is different, but they're all living in the neighborhood. And so now you understand that if this is the your level with a you're dealing with a tumor that has so many different properties. Okay, so clonal evolution, etc. So a cancer stem cell divides both asymmetrically. So this is asymmetric. This is asymmetric. Um, this is all asymmetric division because it gave rise to different things. All right, so it's asymmetric division, and it can divide symmetrically. Symmetrically means this one is symmetric. That's the one that is asymmetric. It's giving rise to its own ones. Okay, so it can give rise to some cells that that could be tumorigenic or non-tumorigenic or even non-metastatic. It is just going to become, well, it is going to give rise to different kinds of cells. Some of them may not survive, and it may give rise to a variety of kind of cells. Okay. So one more time. One more time. So these are rare populations, this cancer stem cell. If you have that cancer stem cell, then you have a problem. So now we're talking about the one on the right hand side here. If you have that cancer stem cell and they're just one or two, then there will be a problem. And so they've been found in these leukemia and in colorectal cancer. And so um, so we have to understand, me as a molecular biologist, that they have different gene expression, different signaling pathways, and so therefore I would in this situation I would have to again see if there's any certain gene expression and do targeted therapy accordingly. So the bottom line is that these cancer stem cells can not only initiate, but they can uh, uh, help in metastasis, recurrence, and drug resistance. Okay, they can cause drug resistance. Why? Because you think you are treating for one, but then by then some of the cells have grown and they have developed a different mutation, and so that drug, the one that was working, will not work anymore. So cancer stem cell related therapies have been have been designed. They did not work too well. I told you the other day also. Somehow they did not work. They did not work too well. So I think I'm almost done. Oh no, I'm not done. Okay, so again, this is just their properties. That what is the resistance due to? Because you have a mixture of folks who are working in a teamwork together, and so some of them will throw out the drug. Some of them will transport the drug out. Some of them will have different kinds of properties, and some of them will not die either. And so all of that, because of all that mixed level, so they will tr- you will they will survive. So that's the bottom line. Okay, so they can survive better, and so they're less than 1% of the population. So you cannot see them beforehand. So now this is what I wanted to tell you, that if there's any way to by not by visual, but really by different kind of omics, by different kind of properties, to from AI to find out the presence of these cells. then that would be easy to handle on early on. Okay, so what can you do? You can target all these different signaling molecules. And so now you know that the CDs are like surface molecules, so you can target surface molecules if you find them. And so you can target this transporting cassette if you know that it has that particular aberration in that. And then if you know that it makes vascular endothelial growth factor, if some of them are making that, then you can uh, you can use a inhibitor for that because there are VGF inhibitors. And if there are other signals and we can identify, then we can target them. So the bottom line is that they can be, you just have to know and then you can target them. So it's all a mix and match approach. This is all hypothetically really nice, but it hasn't worked out really well. And so I will not talk about this one and just to there's another one that I just need to talk about. So you can try one of the best ways to do things is to have really have immune therapy. And because the stem cell therapies have not worked too well, so it's kind of moot. But essentially, that there's you can keep we can again keep trying. There's opportunities. Just because it did not work in the past doesn't mean we cannot go and revisit. So with the new knowledge, we can go back and revisit it. And so in some cases, mitochondria have been targeted. And if one can target in these cancer stem cells, if one can target just the mitochondria because they probably work a little bit different. Remember that they are working in hypoxic conditions, so why not target the mitochondria? So why not look at ways by which the mitochondria can be kind of like destroyed? Those mitochondria that are in the stem cells. And so these are, we don't have to go into details, but I'm just trying to tell you that there are certain pathways and certain ways to examine this. This is the mitochondria. The mitochondria is the powerhouse of the cell. It makes ATP. And all I'm just saying is that if you know what are the surface markers on this mitochondria, these surface markers, then you can just target these special mitochondria markers that are in the CSCs and that can induce stress, and then it can destroy that um, cancer stem cell. Okay, so targeting the mitochondria can be done. All right, we just talked about clonal evolution, so I don't need to talk about that again. And I just wanted to say that how do you get resistance to therapy? Well, the resistance to therapy is because of this clonal evolution. It's because there are different mutations, like I said. So I explained that. And so all these genetic alterations lead to resistance to therapy. So even as you're treating it, some of them are multiplying and getting new mutations, and they're turning off or on new pathways. And so sometimes they can activate different receptors. You don't need to go through all of this, but I have to write it. And so EGFR, epidermal growth factor. So a growth factor is a receptor is targeted. Remember that heterogeneity that these growth factors are substances that go bind to a receptor and tell the cell to start multiplying. So if we just can use anti-EGFR antibodies, then that will prevent that. But the problem with heterogeneity is that it will blunt the efficacy of this antibody only because there's other only because there's other mutations in it already. So, lastly, I think yes, resistance to therapy can occur because of these heterogeneity can also fuel EMT. Remember, we talked about EMT, epithelial to mesenchymal transition. That means those cells that were like, remember, they were like this polygonal, then they turn like this. They turn to this kind of a shape, and then they squeeze in, and they can go through places. So that's your epithelial to mesenchymal transition. And so they and then the tumor microenvironment, etc., supporting cells are reprogrammed, and then therefore they contribute to the resistance. So, uh, so in this kind of therapy, resistance occurs in CRC. That is very, very common, and it's again happening because of heterogeneity. So can we do so opportunities? This was like challenges. So opportunities. How can we? So I really made this. This was really the important part. Sorry, I have to take a couple of more minutes. So how can we use this opportunity of imaging? Because that's the focus for this workshop. How can we use imaging to resolve the heterogeneity and therapy resistance? And so one is big words here: multiplex spatial proteomic imaging. Wow. All right. And so the example that I understand is that imaging mass cytometry. That's called as imaging mass cytometry, and the other names I do not understand them. There are all kinds of various modern ways of imaging. So imaging is not just looking visually at the cell anymore. It is a mixture of a bunch of things. It's a mixture of properties, etc. So anyway, let's just see what this is. So what it is, this imaging, it's like an optical imaging, converting something into an image. By this method, and the technology exists. All I'm just saying is that this can be used. This is like when I use the word can, I'm just saying that even if it's not used, it can be used further for problems in heterogeneity. And so this method, it uses metal tagged antibodies. Okay, antibodies are these Y-shaped molecules wherever you see them, and they will go and specifically bind to 40 protein markers. Okay, so if the cell has a protein marker, it'll go and bind to it because it's an antibody. And you can do 40 different ones within a tissue sample, and you don't have to break the tissue sample, you don't have to cut anything, you don't have to slice. Well, yeah, you do have to slice it, but you don't, but it'll give it to you at a single cell resolution. So you're taking a tissue sample, but you're getting the image of all single cells resolved. Okay, I'm almost done. So this this can identify, anything that's in the microenvironment, the macrophages and everything else. Everything can be identified. So the way that this does is that it does this whole process, which I cannot explain completely. But look at this. This is just a slide. All right, and it's a slide where you put some of the uh, s- uh, tissue sample. Well, I'm not sure if the tissue sample goes into all of this, but the whole the all the individual cells, those different colors, all those different colors, 40 different colors are from 40 different proteins. So so all of these with 40 different proteins. So you're looking at individual cells. You can map all these individual cells, and you can get some kind of a um, image that tells you what cells are there, what cells are not, what type they have, what type they are. So that's spatial. And why is it called a spatial? It tells you, is there another cell here in the neighborhood? Is there a macrophage? Is there a blood vessel? Or is there a fibroblast? Remember those names? So this is proteomic spatial imaging. Very, very new stuff. And I'm saying that this is a opportunity to use it for this because it's already doing the environment. So why can it not do a heterogeneous population of stem cells? That's my that's what I'm trying to say to you. And of the next two, I'll only talk about um, one of them. So the clinical ones are that you can do PET and you can do functional MRI, etc., and endoscopy. Those are straightforward, and then you can get heterogeneous cells. Now I want to talk about the third one. The third one is spatial transchromics again, but done with in situ RNA imaging. Okay, so you have DNA and you have RNA in your cells, and so it is measuring not the proteins but the RNA. I mean, how cool is that? And so it was really hard to find good pictures. Let me see. So essentially, what's happening is that it can it can be used to map the gene expression. Oops, I went ahead. The gene expression within a tissue's physical structure. So you have a tissue sample, you don't have to break it into anything, and you will get you will be able to see how all the cells are, you know, you can map them for their RNA content, for their RNA sequences, sorry, and you can then see who is present and who's not present, and so what is there in the tumor microenvironment, because you are able to identify them. And so therefore this is also spatial. And so what it is that you create this image. You don't get an image of cells, you create this image from all the kinds of RNA that you get inside the cell. You create this different colored image of different kinds of cells, and that it tells you that, okay, there's a good number of these kind of cells, a good number of these kind of cells, and we already know what that RNA stands for. And so then you're creating, so it's just like you're hearing a lot of noise, and you're creating a image from there. And so this is the overall at how it's done. Spatial trans, oh God, I can't pronounce, spatial, spatial transcriptomics and RNA mapping. Okay, so the whole thing is just using all these different fluorescent probes for all kinds of um, to determine the RNA, different types of RNA that's in there. But then in the end, you're just creating this whole image. All right, so it's all image guided, and you get some kind of a look from it. Alrighty, and I think that was pretty much it. I did have to take some extra time, but I hope that helped you. So what did we do today? We did